So you're very welcome to our session today. Just to say from the outset that we will be recording this session, and I hope that's okay with everybody. And so this, the reason we're recording it is so that we can share it with anybody who has missed the session today. I would like to welcome in a very special way our guest speaker for this afternoon, Dr. Sinéad Fitzpatrick. And Dr. Fitzpatrick is a GP based in Waterford, and she has a special interest in women's health and menopause. And just to say, I suppose we're trying to keep the session to an hour because I know some people may be on their lunch break or rushing to somewhere else to another meeting at 1 o'clock. So if it's okay with yourselves, we probably won't have time today for questions on this session because Dr. Fitzpatrick would like to cover as much as possible. But if you have any queries, if you want to email me after or during it, and we will put them to Dr. Fitzpatrick afterwards. And she said she's more than happy to come back to us with some responses to those. So my email address, it's Deirdre A for Anne .dunne, DUNNE @hse.ie. So I am delighted to welcome Dr. Sinéad Fitzpatrick, and I'm going to hand over to Sinéad now. Thank you.
Okay, thanks very much, Deirdre. Can everybody hear me there? Do you think okay?
We can hear you. I'm not seeing you at the moment. I'm not sure. Is that something to do with the WebEx?
Okay, this is all very alien to GP. We're not used to being on camera. So does that work there now?
No, we're not seeing you now, Sinéad, at the moment, but
okay.
Hopefully that will come up.
So I might just let my IT friend here have a little look, and then we'll...
So if everybody else could just make sure that you have your cameras turned off and that you're on mute, that would be a great help. Thank you. We have a lot of participants today, which is great to see. And thank you for taking the time to attend.
Cameras on. Automatically select. Should be okay now, shouldn't it?
We can hear you perfectly anyhow, Sinéad, if you want to start whenever. Maybe the camera might kick in.
Camera working? No.
No.
No. Okay. So look, I'll crack on anyway, and if I pop up, hopefully I won't frighten everybody. We'll have a look. So as Deirdre just said, I'm a GP in Waterford, and God, I've been a GP now for longer than I care to remember. But I did all my training here, and actually in the southeast, and actually worked in Luke's for a year, as well. So Kilkenny's quite familiar to me. I suppose we started a dedicated menopause clinic in the surgery about 2 years ago now. And I suppose there was a couple of reasons for that. I suppose I just feel that when women come into us as patients, you know, to discuss menopause, it's often brought in as part of a list of other things. So they might be wanting to talk about a skin lesion or whatever it is, and then it's kind of brought in at the end of the consult. And I think it kind of deserves a little bit more time and attention than it gets sometimes. So that's why we sort of went ahead and created a kind of a dedicated space for menopause. So normally when people come to us, their first appointment is anywhere between 40 minutes and an hour sometimes to talk through everything. And often people go away with some information to read and to think about things and come back. So that's kind of, I suppose, what we run 1 day a week in Waterford, as well as the regular GP clinic. So I suppose just a little bit about today then. I'm just going to try and click on here to the next slide. Does that work there? Yeah, so for today, I suppose the first thing really is just to educate and inform people. I think there's a lot of talk around menopause at the moment, and there's so many information sources out there. And I suppose one of the drawbacks of the modern age is that you don't always really know if the information you're getting is accurate, and if it's, you know, scientifically based, and if it's maybe biased by somebody who's trying to sell products and that. So I think even if you never go down the road of treating menopause or HRT or learning more about it, just to know a little bit about what the up-to-date thinking on it is important. The next thing I suppose is just to reassure people. Again, you know, I know there's lots of social media stuff out there, and often when I read through it, what strikes me is just the negativity, I suppose, around menopause, and that it's sort of, you know, life is over and I'm destined to just suffer with these symptoms for the rest of my life. And just to reassure people, I suppose, that not everybody is going to go through that. And those people that do, we do have lots more help and support available now than we would have had maybe for the previous generation, that we're often just told, you know, this is something you have to just get on with. So just to reassure people a little bit. The next thing I suppose is just to empower people, is I think the more that you know about what to expect, the more you know about what you can do yourself to help with symptoms and to help to promote your long-term health and well-being is really, really important. So empowering you with that information so that you don't feel helpless and that you can go and speak to a doctor or a healthcare professional with some knowledge and some, I suppose, reassurance that, look, I know that there's something there to help me, and you can't just sort of say, look, get on with this if I need help. And the last thing then I suppose is just to it'll look to the future, because as we go through the talk, we realise that I do talk a little bit about symptoms and what people are going through, but there's a huge part of it that's looking towards trying to promote our health, our health and well-being towards the future, be that mental health, be that the long-term effects that menopause can have on us, and all the things that we can do to help with that. So I suppose I just thought I'd start a little bit. When people come to the menopause clinic, they fill in a questionnaire beforehand, which gives us a lot of information. A lot of it is about gathering, information on their symptoms, their past history, that kind of thing. But there's a very interesting part on it that we put at the end, where we just say, is there anything else you'd like to talk about, or anything else that you'd like to bring up? And some of the things I suppose that are said can be quite stark and quite powerful. So I'll just put a few of them up here, and you can have a little look and see. Are we okay? Sorry, just 1 second there.
You okay there, Sinead?
Yeah, just the ladies here are trying to sort the camera as well.
We can hear you perfectly.
Okay. So I suppose just while the girls are having a look at the screen here, just to maybe read through some of those quotes from people. I think you can see the first one there that says, is this what I have to look forward to? The next one I'd written down was, is there any hope for me? I'm scared I'm going to lose my partner if I don't get help soon. A lot of people, their symptoms have been causing issues maybe at home, and there's a lot of guilt and a lot of feeling that, they don't want to feel the way that they do, but it feels a little bit out of control sometimes. I want to feel like me again. I had a lady yesterday who said this exact thing to me, that she said, I haven't felt like me for a couple of years, and is there any way I can get back to feeling like me? Which I think is, it's something that comes across very powerfully to me anyway. This is another really common one. I feel, or I worry that I'm developing dementia like my mom did, and I'm petrified. People, if they've got a first-hand experience of a relative, I think, who's suffered with dementia, and some of the lack of focus and the brain fog that can come with menopause can be really, really scary. And it's so common that people will come in and say, is this actually menopause, or is it something more like dementia? Next one, I'm feeling guilty about how I fly off the handle. And another one, I don't feel able to do my job anymore. I go home worrying that I've made mistakes. And absolutely, I've seen people where they've not gone for promotions, or they've decided to leave a job or whatever it is, because of their worries around their performance at work. The statistics then, I suppose, so again, some of these can be quite stark. Some are quite positive, some can be a little bit on the negative side. The first one to notice is 75% will experience symptoms of menopause, and of that 75%, 1 in 3 will say that they're severe. So I've certainly come across people, who say, I sailed through it. They're in for their smear, and you say, last period, 10 years ago, not a bother, no symptoms at all, and those people have sailed through it. Equally, I'll see women who, from their late 30s, early 40s, are coming in with symptoms that are suggestive of perimenopause, and it's having a huge impact on them. 7 in 10 women in a UK study felt that the menopause either caused or contributed to their divorce. So again, huge issues around relationships and things like that, and how when somebody's personality changes, I suppose, for want of a better description, then it can have huge impacts on family life for them. 51% of women, this is a British Menopause Society statistic, 51% of women said that it adversely affected their sex life. 43% of women in an Irish study have said that they consider giving up their job because of their symptoms. Again, issues around confidence, issues around, not being able to cope with the workload that they always would have coped with fine before, anxiety, taking, work home in their head, and all of that type of thing. And 47% of people who have felt they needed to take a day off due to their symptoms didn't feel able to tell their employer that the reason they wanted it is because they were struggling with menopause. So again, something that might be, useful to yourselves is that, maybe speaking to employers and that type of thing can actually be helpful, and being open about it. And the last one, I suppose, very, very sadly, in Australian data, we know that the highest rates of suicide in women occur between the ages of 45 and 49 and 50 to 54. So apparently, I think I've popped up on screen, so now you can see what I look like. But very, very sad statistics there. And I certainly can remember a couple of ladies. I always think back to them in my early career who came to us, and I didn't have any menopause training at the time. Menopause wasn't a topical issue. And those ladies, you know, one of those ladies actually did take her own life. And I often think back now to how maybe things might have been a little bit different for her if we knew what we do now and if the help and support was there for her now. So the next bit, I suppose, then is to move on a little bit to what we said about the education and the empowerment side of it. So there's loads and loads of terminology around menopause and all these new words. And I suppose it's just to get a little feel on what all of them mean. So the word menopause actually means meno being periods and pause is stop. So it means literally your period stop. It's the last period that you have. The average age of that is about 50 to 51, but very individual. As I say, I have women coming in at much younger ages. I know in my own family, the women tend to go on and have periods for much longer, but the average age is about 50. You can really only diagnose menopause then, I suppose, in hindsight, because a lot of women will come and say, look, I had nothing for 9-10 months, thought I was done with it, and then suddenly bang on 28 days, here they are again. So postmenopausal means that it's 1 year since your last period. So if you think about that, you can really only diagnose that in hindsight. Okay, so it's a year or more since you last had a period. The newest one then, I suppose, the newest term that's been bandied around is this perimenopause. And perimenopause basically means the time leading up to your last period. And it's hugely variable, hugely variable. It can be, as I say, women in their late 30s, early 40s who go on to have periods well into their 50s, or it can be 6 or 8 weeks before periods stop, and then that's it, nothing happens after that periods-wise. But the most important thing about this perimenopause is that you will still be having periods during that time. So there has been a tendency for people to go, you know, to speak to their doctor or whatever, to be told, oh, you're still having periods, you can't be menopausal, come back to me when they stop, or come back to me a year after they stop. This is very new in our approach to menopause treatment now, in that we actually treat people now in perimenopause. And in my experience, I think, and we'll go on to talk a little bit about what happens to the hormones at the various stages, but after menopause, it's more of a gentle and gradual decline like this with the hormones. Perimenopause is this baby here. So sometimes we're great, sometimes we're not, sometimes we're struggling. Sometimes we look back and say, I totally imagined how I was crazy last month, but it's not. It's that your hormones are fluxing like this. And often it's the women in perimenopause who are struggling most and maybe would benefit more from interventions from us as healthcare professionals. A couple of other quick ones then is just surgical menopause. So that would be ladies who maybe have a hysterectomy or their ovaries removed. And obviously then you're going to go into a more sudden menopause. And actually some medications like chemotherapy agents and that for cancer can do that to us as well. As a kind of general rule of thumb, surgical menopause often tends to be a little bit more intense and a little bit more severe, because if you think about it, in a natural menopause, you're gradually approaching like this, whereas surgical menopause, it just happens and you're flung straight into it. So that can be quite a challenge for us to treat. And the last one then is what we call premature ovarian insufficiency, or premature ovarian failure was the old term. And that's basically a last period that happens before the age of 40. So we used to always say 45 to 50 was normal. Now it's probably, 42, 43. If somebody's periods has stopped under 40, that's very important that they get to see a doctor, because as we'll go on to speak about in a minute, there are long-term effects to having a menopause that early on our health. So it's important that they're seen. So the next slide, I suppose, just gives a little picture of what's actually happening during our lifetime with our hormones. There's 2 hormones listed here. Now, there is a third hormone as well, which we'll talk a little bit about in a while, but you can see what's happening there. So at birth, low levels of both hormones, then puberty, things seem to, start off a little bit having cycles. During our fertile years, nice and high, we're feeling young, we're looking good, we're fertile, all of that kind of thing is happening. But then once perimenopause hits, we're at that fluxing where sometimes we're fine, sometimes we're low, we're peaking and troughing all the time. And then you can see after menopause that things gradually just peter out like that. So what happens during this time biologically in our bodies is that our ovaries are gradually becoming less effective at producing the hormones that we need to be fertile and to have high levels of estrogen and progesterone. And what happens is that we've got estrogen and progesterone receptors everywhere through our body. So from the tip of our heads to the tip of our toes, everywhere we've got these receptors. And if there isn't enough of the hormone floating around, there's nothing to click and lock into that receptor. And therefore the tissues that aren't getting the hormones they're used to, they start to go, well, look, there's something wrong here. And that's where the symptoms come from. The symptoms are so variable, and that's because we've got these receptors literally from head to toe. So some people will come with dry eyes, some people will come with itchy skin, some people it's joint pain, some people it's more brain issues like focus, concentration, the typical sweats and flushes and all of that type of thing, but very, very variable symptoms. And again, we'll talk about that in a second. So how do we diagnose somebody with perimenopause or menopause? So I suppose if somebody is a year since their last period, they're 48, 52, they come in, they've got sweats, they haven't had a period for a year, that's really easy. We don't really need to do any tests or anything to diagnose that. That patient is postmenopausal and is going through some of the symptoms as a result of their hormone levels being low. Blood tests. So I suppose blood tests is a really common thing that I see coming in as a GP. People will come in and say, look, can I get my bloods done and see where I am? Have I started? How far into it am I? How long more? It's not that simple. If we look back to that slide that we saw a few slides ago with the hormone levels on it, depending on the day, depending on the time of the month, depending on even the time of the day, I could do a hormone level on you and I could say, no, you're absolutely, no, you could become pregnant this month if you were looking to become pregnant. But if I did that 2 or 3 days later, your estrogen level might be rock bottom. So we're not going to get an accurate picture because of that fluxing that's going on. So as a general rule of thumb, blood tests are not really that helpful to us, apart from that premature ovarian insufficiency that I mentioned a few minutes ago. If somebody comes into me late 30s, 40, periods have gone very irregular or stopped, I usually will do bloods on those because we need to know if that's a premature menopause or not. So the next term I put up here then is what we call a clinical diagnosis. Now, I'm not sure if I've got any, clinicians out there, but you may understand this term. It means that we diagnose something based on the symptoms and signs that the patient comes to us with. So in the case of perimenopause, it's a change in periods. So somebody says, always 28 days, the last 6 months, they got a little bit more frequent, then I missed a few. There's a change in them. The second thing in the clinical diagnosis is symptoms. So people will come and in our surgery anyway, they fill in the symptom form and we look and we say, yeah, look, that sounds like it could be perimenopause. And the third thing then is the typical age group. So really anybody from 41, 42 up with a change in periods and with symptoms suggestive of perimenopause, we're very much thinking, could this be perimenopause? So as I've said there, typical age group, period changes, and new or worsening symptoms that go along with perimenopause. And I suppose the next point here is something I mentioned earlier. It's so important to be aware, to be empowered, to know this is what my cycle is. This is what I normally feel like. I know this is different. Have I always been an anxious person or have I suddenly just become anxious? It's really important to sort of start getting keyed into that and to maybe jot things down, or there's an app that I'll mention later on that you can actually start to log symptoms on. And it's really useful because you can get a look back at 3 or 4 months and actually go, well, wow, like I actually don't sleep 3 weeks out of the month, or I thought I was doing fine, but I've been weepy 4 days at work in the last 2 weeks, or whatever it is. So sometimes noting it down and actually, focusing in on it can really bring it to our attention that, okay, there is actually something going on here. So that's, again, what I talk about there, tracking our cycle and our symptoms. And then the premature ovarian insufficiency ladies definitely would need to come into us for a closer discussion and maybe bloods there as well. So just, I suppose, again, quite negative. This is something I came across to describe the 7 dwarves of menopause. We're itchy, we're bitchy, we're sweaty, sleepy, bloated, forgetful, psycho, and you could keep going on. And that's probably, I suppose, the perception that's out there a lot of the time. I suppose it's just to make the point as well that symptoms are so variable. As we said earlier, not everybody is going to get symptoms, but some people will, and sometimes they will be very, very severe. So if we look at symptoms, the typical ones, if you ask anyone on the street, would be our vasomotor symptoms. So that's our sweats, night sweats, flushes during the day, the sensation of heat coming up. Cold sweats actually are quite a common thing as well, and it's something that women often come in and wonder, is this normal? Just a feeling of cold and chill coming over us. And also included in that then would be palpitations, and that's quite a common presentation as well of perimenopause, women who are starting to feel an awareness of their heartbeat, their heart is racing, all of that kind of thing. And they may come to us looking for heart investigations, but actually when we delve into it and come down to the nitty gritty, it's actually more a hormonal based thing. Musculoskeletal, so joint pains would be hugely common that I would see, and it's actually one of the things that responds very well to treatment. The brain and nervous system then, so a lot of mood, anxiety changes, and I would see people, I suppose, sometimes people come and say, look, I've always been a bit of a worrier, I've always had a tendency to low mood. They might be on an antidepressant already, But they say there's just something different about this. There's things that I'm worrying about that never bothered me before. Driving is a huge one that I see. So people say, like, I've come from Waterford now today, and people would say, I could never have batted an eyelid in the car, and off I go. But for the last 2 days, I'm worrying about, oh my God, I have to get in the car and drive up the motorway, things like that. So new onset, or people who say I was always a bit of a worrier, but now this has gone off the charts on me. And obviously then the sleep and brain fog would be other aspects of that. The genital urinary ones will be one that I'll touch on a little bit later. Just, I suppose, localized symptoms around the vagina as regards dryness, irritation, getting urine infections a lot. Or similarly, I suppose, people who come to us thinking they've got a urine infection, and every time we dip the urine or we send it off, nothing comes back on it. That's actually quite common as well in perimenopause. So we can see it's a really mixed bag. And, I think tracking them and writing them down or putting them in the app and saying, well, look, yeah, every time before my periods, I'm starting to notice this, and then I'm fine the week after, or I didn't have this 6 months ago, but now I do. That's really important information for you and for us as the doctors. And I suppose the last thing that's quite common in perimenopause is, is it perimenopause, or is it just that I am so busy? I've got a husband, I've got kids, I've got a job, I'm caring for, an older parent, I'm on the go with kids' activities every night of the week, I haven't had a proper dinner in whatever length of time. And that's a really common query, and there's no definite answer to that. Is it just that we are too busy and we try to take on too much? And sometimes in these ladies, we will have a chat, and actually what we will do is we'll try a supplement, or we'll try some HRT for maybe 2 or 3 months and get them to keep tracking their symptoms. And I would say, I suppose, on balance, a lot of them come back and say, I'm way better. Oh my God, I didn't realize how much I was suffering. I'm way better. But equally, some women do come back to me and they do say, look, I don't really think it made much of a difference, or, there was loads of stress going on at work and I managed to talk to somebody, and that's, my job is a bit easier and I feel much, much better, and I think I'm going to hold fire and see how I go. So that can happen as well. Sorry here now. So next slide. So how long, I suppose, is another common question. Very variable again. There's no, I think that's one of the main themes of this, is that there's no set formula to this on how we're going to feel, how long it's going to go on for, but it's very individual. The average length is about 7 years. I've seen people have everything done and dusted symptoms wise in a couple of years. Equally, I do see people where, 10, 12 years later, I've seen ladies in their late 60s, 70s still come in and complain of hot flushes and sweats. The other thing to note is that the symptom profile might change. So you might start off in early 40s with irritability and anxiety and not sleeping. But then by the time you hit your mid 50s, the sweats and flushes might kick off, or vice versa. So again, there's no kind of set formula with it. Sometimes symptoms can persist. So yeah, it's quite common that some people would come in and they're still suffering more than the 7 years. And I suppose it's important to remember, if you remember back to that little graph, the hormone levels stay low. So it's not that we go through it for a bit and then they sort of go, oh, everything's okay, and pop back up. They're going to stay low. Some people respond fine to that and their bodies adapt and they get on fine. Other people find that they don't adapt as well, and they are going to need a little bit of help to deal with the symptoms. Sorry here now. So the other thing, I suppose, that I think is really important to talk about, and it is getting a little bit more airtime, all of the focus, I suppose, initially was on symptoms. So sweats, flushes, not sleeping, mood changes, all of that. And there's a bit of a tendency, I suppose, to think that, well, once I get through that, I'm fine and done and dusted, I'm back to normal. And you may find that you adapt and your symptoms settle and all of that, but there are some key, I suppose, health things that we really need to be aware of going forward, because after menopause, when that estrogen drops off, it can have significant effects on several systems in our body. So I'll just touch on 2 of them today because of time, but there are others as well. So the first one would be heart disease, cardiovascular disease. So that's heart disease and stroke. The second one would be osteoporosis, which is brittle bones. And then dementia, which I don't really have time to go into today, but it's something that's very topical at the moment. So we have lots of studies going on into, whether lack of estrogen is a contributing factor to this. So I'm going to talk a little bit about cardiovascular disease. So if we look at it, you probably all know that covers angina, heart attacks, strokes, stents, all of that kind of stuff. Before menopause, when that estrogen is nice and high and we're young and all of that type of thing, estrogen protects us from heart disease for a lot of people. Now, I won't say that we never hear of a premenopausal lady having a heart attack or a stroke. It can happen, but there's usually another factor behind that. We're protected because of our estrogen. But once that estrogen starts to drop off and we start to go into postmenopausal years, our risk starts to rise, and it actually reaches that of men by about our mid-60s. I always mention this to ladies who come to the menopause clinic, and it's a bit of a shock to them. The number one cause of death in Ireland, the UK, Northern America, the Western part of the world, is actually heart disease. So more women are going to die from a heart attack or a stroke than are going to die from breast cancer or cervical cancer or any of these things, you know. And it's a little bit of a shock because I suppose there's so much focus on those breast cancers, women's health type illnesses, and we don't really talk a lot about the cardiovascular risk. If you live in this part of the world, you're 6 times more likely to die from heart disease than you are to die from breast cancer. Again, because of what we spoke about there, the estrogen levels dropping and losing that protective effect it has on our blood vessels and our heart, we're 5 times more likely to suffer a heart attack after menopause. Now, for some women who are low risk of heart disease, that may not be a big thing. They might be not smoking, they might be healthy, active, they don't have a family history of heart disease, they don't have high blood pressure. You know, it's 5 times a low risk. But if you have a lady who has a strong family history of heart disease, she might be a smoker, she might not be very active, she might be pre-diabetic or diabetic. This risk is significant. So sometimes it will colour our decision, I suppose, as to whether somebody might try HRT or not. They might say, look, I've got a lot of risk factors for heart disease, a strong family history. I'm actually going to go on HRT to protect my heart and my blood vessels, as opposed to not being able to manage my flushes or my poor sleep. We know that if we use HRT during our perimenopause or within 10 years of the last period, so say last period at 50, if a lady comes to me at 55, 56 with concerns around heart disease risk, we know that her going on to HRT will actually reduce her risk of heart disease later in life. There is a little caveat there that it's best if you start that closer to the last period. So if you come in 9 years after your last period, you're probably not going to get the same benefit as if you come in a year before, but there is some benefit to doing that. The other thing I suppose to mention here, and you'll see this is a common theme later on in the talk, lifestyle measures are so important. So I'm not here today to say everybody should go on to HRT, everybody should go on to a statin for their cholesterol, everybody should go on to blood pressure medication. There's huge benefit from these lifestyle measures. So smoking, exercise, our diet, our blood pressure and our cholesterol. And as I say, for those ladies with the lower risk of heart disease, they may say, look, I'm going to focus on lifestyle and I'm not going to go down the road of HRT. And that might be absolutely fine for them. So again, just to be aware of the fact that lifestyle can have a huge benefit in this area. The second one then to talk about is osteoporosis, which, as we say, is brittle bones. And I suppose the big thing with brittle bone disease is, you know, people will be aware of people breaking their hip. The most common group of people who get osteoporosis are postmenopausal women. So as women, we're a little bit, you know, we're more susceptible to osteoporosis anyway, because we don't reach the same peak bone density as men, but our hormone makeup has a huge impact as well. So you can see here, oops, sorry, next slide, that there's a huge drop in our bone mineral density. BMD there is bone mineral density. Once that estrogen starts to drop, it's like a ski slope, a black ski slope, our bone density drops off a cliff. So if you've been, you know, someone who hasn't had a very high peak bone mineral density to start with, and that's down to things like nutrition as a child, your genetic makeup, how active you've been in your teens, 20s, 30s, that type of thing, you may be starting from a lower point, so that drop off can be quite significant. So again, like I say there, if you've got all other riskers, you may actually mean that your bone mineral density drops off at a much steeper rate. 1 in 2 postmenopausal women will develop osteoporosis, and 1 in 3 will fracture a hip. And again, I'm not 100% sure on the audience I'm speaking to here, but anyone involved in, you know, hospital healthcare will know the huge toll a fractured hip takes on a patient. A lot of people won't ever get back to independent living. They won't, you know, they may not make it out of the hospital. They may get a clot or an infection or whatever it is. So it's a huge event, and it's something that really we need to be looking at trying to prevent if we can. So to move on then from all the doom and gloom and we're all doomed, what can I do about it? Okay, so there's loads and loads and loads that we can do about it. Like I say, the lifestyle measures, I feel totally underestimated, particularly at the moment. There's this focus on get the most expensive supplements, you know, what celebrity is promoting a supplement that's going to cost a fortune, but is going to make me back to when I was 20. Lifestyle measures can have the same effects, and we'll talk a little bit about them in a minute. The next thing then is CBT. So CBT actually, which is cognitive behavioral therapy, a form of counseling and talking therapy, that has been shown to have huge benefits on the mood changes of menopause, the anxiety, also sweats, believe it or not, and sleep as well. So CBT is absolutely something that that can be used and possibly is underutilized for menopause. The over-the-counter remedies, which I'll talk a little bit about in a minute. We also have some non-hormonal prescription medications, which you would need to go to your doctor for. But if somebody has worries around HRT and or isn't keen to go down that road, then we do have some options there. And then obviously our HRT. So the lifestyle measures, I'm just going to flick over here. Sorry, now I'm following my slides here. So The first thing, I suppose, is a healthy diet, okay? And I suppose something that becomes really, really important when we hit menopause is our protein intake. And we'll talk a little bit about it again in a minute. But I suppose weight gain and weight loss is a huge concern for women when they come to us around perimenopause, that they're finding it hard to lose weight and that type of thing. So I see lots of women who are on, 1,000 calories a day, 1,200 calories a day, meal replacement diets, this kind of thing. You may lose the weight, and I suppose that's another debate for another day as to whether it's a long-term solution to losing weight, but you really have to be aware of the effects of these low-calorie diets on our bone health and our heart health and all of that. Secondly then is sleep. And I suppose there's definitely people out there laughing when I say that, because sleep is such a huge issue for people who are around perimenopause and menopause, and it's probably a whole talk by itself. But if we can try to get our sleep better from relaxation methods, CBT, medications possibly from your doctor, all of that kind of thing, it's really, really important at helping with coping with the symptoms. So if you don't sleep and then you get up exhausted the next day, you're going to be irritable. You're probably not going to eat very well. You're probably going to say, I'm too tired to go for a walk, or whatever it is. You're more likely to make mistakes at work. All of those kind of things can spiral on from sleep. So trying to get on top of the sleep and talking to somebody about that is very important. Stress management is the next one there. And again, similar to the sleep, it's something that, it's kind of underestimated. And I think we just accept that it's part and parcel of life these days. But I do sometimes see this menopause consultation when people come in as a chance to just take stock and go, do you know what, do I need to be doing all these activities? Can I ask somebody else for help? Am I prioritizing my day? Am I doing things that maybe don't need to be done and are putting me under pressure? Can I talk to somebody at work about maybe, cutting back on my workload? Do I still need to be doing the same amount of hours? All of these kind of things. So having a little look at where we're at, and that can really help with the sleep and the stress management part of things. Exercise, which we're going to talk a little about in a second as well. Muscle is really important. So not bodybuilder muscle, but building muscle, and also our steps and being active and just getting up and about. And I took, I think, 3 flights of stairs to get up here today. So my watch is happy with me going home after that. Caffeine and alcohol, both of these can definitely affect our sleep, and they can affect our mood, and they can also affect our sweats and our hot flushes and night sweats and that type of thing. So something definitely to watch. I suppose the other thing I like to say to people is that something is better than nothing. I think in this age of all these fitness influencers on social media that, they work in gyms, they don't have kids. So they go into work, they're all day in a place where they can eat well, they can get their workout done. They're not coming home, doing homework, school run, all of this kind of stuff. And then, having to fit their exercise around that. That's the ideal. I think if we look sometimes at there's a lady that I've spoken to before about just coaching and weight loss and that kind of stuff, and she talks about imperfect action. And imperfect action, you may not get 10,000 steps done every day, but if you get 6,000 steps done, that's better than doing 2,000 steps. So the last point I think I have there is just to be kinder to ourselves. We have a lot going on. We're in a stage of life where there's a lot going on inside in our bodies that we don't really have much control over. And I suppose just saying to myself, look, I'm going to do what I can. So if that's 5 minutes at lunchtime, 5 minutes after work, and I'm going to take the stairs in work, it's better than nothing. And okay, if you look at your favorite Instagrammer and they've done a workout and walked 20,000 kilometers and eaten 100 grams of protein that day, they maybe didn't have to get through the same amount of stuff that you had to get through. So be kind to ourselves, and also realize that doing something is better than doing nothing at all. So I'm just going to talk a little bit then about protein as part of our diet and our nutrition. And I suppose this is very, it's probably very well known at the moment, but it's really over the last few years that's become so. So we lose muscle as we get older. There was a study, I think, done in Harvard that says that after our 30s, so 30, which to me is young because I'm well past 30, we lose 3 to 5% of our muscle mass every decade. And as we approach 50s and 60s, that actually increases more. So we're losing muscle as we age, okay? That has huge consequences on our body. It has consequences on our strength, okay? It also has consequences on how we can do our daily tasks and our fitness levels. As we get older, it has a huge impact on our falls risk. So we know that older people who are frail and don't have as much muscle and don't eat as much protein as others are more likely to fall and have malnutrition. It has a significant impact on, I suppose, the proportion of fat and muscle in our body. So if we've got more fat than muscle, and as we get older, we store that around the middle, which I know most of us are probably familiar with, that has a huge increased risk on our diabetes risk, on our cancer risk, on our heart disease risk. So if we can have more muscle and less of the body fat, that has much more beneficial effects for our chronic disease risk, like heart disease and cancers and diabetes. And the other big one then that we spoke about already is our bone density. So when we talk about bone in a minute, we'll talk about how exercise is really beneficial for that, but equally protein is really important, not just the calcium and vitamin D that we might be aware of. We know that if somebody has osteoporosis and they've lost bone density, if they've also lost muscle mass from not eating enough or not exercising enough, they're actually at a higher risk of a fall, and they're also at 4 times the risk of a fracture. So people who have the same bone mineral density, but who aren't training or eating enough protein, they're much more likely to fall, and they're 4 times more likely to fracture, which is, I think, a really powerful statistic. So we can avoid this by having enough protein. And I suppose we're all familiar with the protein shakes and all that kind of stuff. It doesn't have to be that complicated, but protein powders and all of that are a perfectly good way of getting in the protein. There's a lot of talk about how much should we have. And really, unless you're somebody who's competing in strength competitions in a gym, about 100 grams of protein per day for women around menopause is adequate. So if you look at that, you can look at the amount of chicken that you eat, Greek yogurt, all those kind of things. I would normally say to people, try to space it out, that you're having 20 to 25 grams of protein with each meal, and that it works out then at about 100 grams in the day. The other big plus, I suppose, of protein is that it's very filling. So if you have a slice of toast, it's fine, however many calories and all of that in it, but you're probably going to be hungry an hour later. Whereas if you have some Greek yogurt with some fruit or something like that, or if you have an egg with some cheese or something like that, that's much more filling. So again, you're less likely to be snacking, and it's going to help with that concern over the weight gain. Protein is the building block of muscles. So if we don't take in enough protein, it doesn't matter how much exercise you do, how much weight you lift, we're not going to grow the muscle. So the more muscle we have, the less fat we have, the stronger we are, the stronger our bones are, the less likely we are to develop diabetes, heart disease, stroke, all of those things that we spoke about earlier. And like I say, there are 20 to 25 grams of protein with each meal, about 100 grams a day. Sorry, just click to the next one there now. So the next one then is just to talk a little bit about steps. So again, we all have these babies going around, and we're all competing with each other as to how many steps we can get in. And it can get a little bit overwhelming as well, I think. So again, it was just something that I mentioned there earlier. The major benefit, if you look there, is the major benefit, the left-hand side here is mortality. So it's death rates, okay? And then the bottom is steps per day. The big bang for your buck there is between 6,000 and 8,000 steps a day. Okay, so you can see if you're less than that, 2,000, 4,000, your risk of dying is much, much higher. As you go over 8,000 to 10,000, there's actually not a huge much to be gained for your health. Now, obviously, some people are training for marathons, or walking is their stress relief or whatever, and absolutely that's fine. But I think not to feel the pressure of having to get up to this massive numbers of 10,000, 20,000 steps a day. If you can go from doing 4,000 steps a day to 6,000 or 7,000 steps a day, you're doing a lot for your long-term health and your chances of living longer. So the next thing that I'm going to talk about is strength training. Okay, so again, like we mentioned earlier, we lose muscle as we get older. From 30 on, we lose muscle, which is a bit scary. And then once we hit perimenopause and menopause, as the estrogen is dropping, we're losing even more than that. As we mentioned, we've got a higher muscle mass. Everything is just better from a health point of view. Stronger bones. And the other one, I suppose, that I always mention to ladies here as well is because incontinence and the vaginal symptoms are something that we see quite commonly. Just because we're losing muscle here, it means we're also losing muscle elsewhere. So our pelvic floor is one of the first things that people will come into. And I was always taught as a medical student, incontinence and all that is way down the line, 60s and 70s. More and more we see women coming into us in their 40s with incontinence and issues around pelvic floor. And one of the things that we would always suggest to them is to increase their protein intake. So if we just look at this slide here, I just think it's quite interesting. The first one is a 70-year-old sedentary person. So if you look at the white ring on the outside, that's fat. And then the darker on the inside is muscle, okay? And if you look at the second one, that's a 70-year-old triathlete. Now, I know I'm contradicting myself by saying we don't have to all be training all day, every day, but this obviously is the extreme. But that 70-year-old's leg is mostly muscle with very little fat there. So you can just see the effect that muscle has, or that training and staying active has on our bodies. So just to move on a little bit more then, some of the lifestyle stuff, the over-the-counter remedies, I suppose really, really popular, really, really common at the moment. I'm just keeping an eye on the time there because I tend to lose track. I suppose the big issue with them is that they're not regulated, okay? Now, they're very popular, and a lot of people would see them as probably being safer than HRT because of all the old controversy around HRT. They can be very helpful, and often when I see a woman come in, we might say, look, you know, is it perimenopause? Are we not sure? You know, she's not maybe keen on the idea of HRT just yet, whatever it is. And we might often say, look, we'll go with the supplement for 3 or 4 months. They usually have a combination of things in them. It's like there's your multivitamin. They often have magnesium in them. They often have things for sweats like sage and black cohosh and all of this kind of thing. And it's kind of a combination of things, your B vitamins, all of that. And absolutely, I think they can be used. I can't, though. I can show scientific studies and say HRT does this and HRT does that. I can't really do that for the supplements because it's a very unregulated industry. So a lot of it is what we would call anecdotal evidence of people coming in and saying, well, look, my sister thought this was good, or my friend thought it was good, or Davina McCall said it's great, or whatever it is. The other issue I suppose I would just have with these is the cost factor. I think, like everything that is topical and that, you know, people start to talk about a lot, there's a huge menopause industry out there at the moment, and it seems like every person now is coming out with their own brand of vitamins. I think Pennies have menopause clothing, you can get menopause sheets, all of these kind of things, and we just kind of have to be careful that we're not being manipulated, and you know, that it's something that doesn't need to be that expensive. That would be another concern I have around them, but I have to say lots of women will try them. Sorry here now. That's the other thing just to note as well, that they can interact with other medications. So it's just maybe important to check with the pharmacist or with the doctor if you are on other things, like St. John's wort now would be one in particular that can interact with other medications and cause issues. So just be important to check if you're on other medication. And the last thing I suppose to mention about them is that they work on the symptoms only, really. Now, some of them will have maybe omega-3, which is, you know, it's good for heart health or things like that. But really, you're not getting the heart protection. You're not getting the bone protection that you're going to get with HRT by going on a supplement. But absolutely, it might help you sleep better. It might make you less sweaty in work. It might make your energy, all of those kind of things better. But maybe worth the go, but some people do come back and say they haven't helped. Some people find that they get through with the supplements. Again, a quick run through these because it's probably something you're going to talk to your doctor about. We have lots of different options. I suppose commonly where we would see this is maybe in a lady who's had breast cancer who has been told, you know, that maybe she would be advisable not to go back onto HRT. Again, that's something we could talk about in more detail. We would now never say no to somebody like that. We're very much of the thinking now that it's a joint decision between maybe the menopause specialist, the cancer specialist, and the patient. And I have 2 ladies who have had breast cancer who have decided to go back on their HRT because they felt so awful. But that's a talk for a different day. But these medications can be useful sometimes if people are a bit nervous of HRT or maybe don't want to go back on it. So the first 2 that I mentioned here are their SSRIs and SNRIs. So they're various antidepressant and anti-anxiety medications. So obviously they can be helpful for the mood and the anxiety changes, but actually they can also be very helpful for sweats again, and night sweats, which again, as a knock-on, can help with sleep and therefore affect mood. Gabapentin is the next one, which is it's an anti-seizure drug. We also use it for nerve pain, and at low doses we find that is useful sometimes. The next one is clonidine. Clonidine is an old-fashioned blood pressure medication. I've used a bit of it. I find it works initially for people, but it does tend to wear off. So often people will come back after 3 months saying, oh, thank you, doctor, this is brilliant. 6, 8 months in, they're back saying, you know, can I double the dose? Can I take more? And it's not maybe as effective as it was. And the last one then, or the last point there, again, like the supplements, these are for symptoms only. So you're not getting protection for your bone or your heart or your stroke risk, any of that with these. It's the symptoms only. So the next bit then, I suppose, is the HRT, which when I was a student was completely, you didn't even mention HRT. It was gone off the market. It was evil. It was going to be something we read about in the history books. And now here we are telling everybody that it's absolutely fine to take it and they're all going to feel amazing on it. So it's basically exactly what it says on the tin. It replaces the 2 hormones that we spoke about earlier. So estrogen and progesterone, okay, and that's what gets replaced. We have now, again, I could spend the whole talk talking about HRT and how we give it and the different choices. I don't have time to go through it all today, but we have various ways of giving it. There's a tablet form, there's a patch, there's a gel, there's pessaries, all of these kind of things. And that's something, if you decided you were going ahead with that, your doctor would go through with you and see what's the best for you. So I suppose what we have now is what people would call new HRT. We've got what's called body identical HRT now. So some clever scientist somewhere in a lab has managed, using sweet potatoes, apparently, believe it or not, to make the exact structure, estrogen and progesterone, that our ovary makes. And that's actually what's in the new body identical HRTs. And the studies are backing up the fact that these do seem to be safer. Okay. The other thing that's changed a little bit is that we would have always said before, 5 years and that's it, that's your lot, you're not getting any more. Now, again, very much like the lady with the breast cancer, we talk to patients and we say, how do you feel? Will you reduce down and see, you know, can you come off it? Some ladies say, I'm going down in the grave with this patch on me, make sure there's a fresh patch on when I'm in the hospital. Other ladies then will say, look, I'm going to try and wean down, and sometimes will come off it if they find that their body has adapted and their symptoms have settled. So for most women, the benefits of HRT will outweigh the risks. Now, obviously, there are always individual scenarios, and you know, often even me, we have a good menopause support kind of group on a Telegraph group there, and you know, the most experienced of doctors will put cases up there most days saying, look, I have a lady who has this and that, what do other people think? And basically all the other menopause specialists from around Ireland will offer opinions and things like that. But for most women, the benefits will outweigh the risks. Most women will find their symptoms improve. Most women are getting some prevention on their heart disease and their bone disease risk and all of that. And for most women, it's a positive thing for them. The risks, which we'll talk about in a second, they're reversed once you stop. But again, there's no time limit. So once a patient is aware that, look, as you go on, the longer you go on, there is a small increased risk of breast cancer. You know, but if that lady says, look, I'm happy to accept that risk, I feel great, my energy is great, I feel like the old me again, I'm living my life to the full, and if I get a breast cancer, I'll deal with it when I get it. Other women are more conservative and say, oh no, I don't think I can take that risk, and I'm going to stop, and I'm going to, you know, try and manage through the symptoms as best I can. Like I say, it does ease and cure most of the symptoms, and it has benefits on our chronic disease risk as well for the future. So I suppose this is what happened when I was a young student up in Hull Street in UCD back in the early noughties. A study came out in 2003 and 2002. The Women's Health Initiative and the Million Women study came out. Basically, they came out and they said, all these women on breast cancer, they're all getting breast cancer, all these women on HRT, sorry, they're all getting breast cancer, they're all getting heart disease, we have to stop this, it's so dangerous. And literally overnight, panic. Doctors wouldn't prescribe HRT, pharmaceutical companies stopped making it, patients wouldn't take it. Even if you had a maverick doctor who was saying, look, I think it's okay, the patients wouldn't take it for you. So we were told in college, you know, you won't even be lectured on this, it's for the history books. So I suppose there was a whole generation then, probably maybe 2 generations of women who just struggled on, had their symptoms, went to their doctor. Maybe sometimes were told, you know, you just have to get on with this. It's part of being a woman. We don't have anything to offer. And also, I suppose then we're seeing the aftermath of that now. Ladies in their late 60s, 70s coming to us with osteoporosis, heart disease, stroke, all of this because they didn't have the opportunity to talk about HRT. Over the subsequent years then, I suppose people who had interest in women's health looked back on the study and they realised that it was quite a flawed study. There was lots of things that was an issue with it. And I think, yes, I do. So I have a few reasons here as to why it was flawed. So the first thing was the type of HRT. Like we mentioned there a minute ago, the body identical HRT was not a thing back then. And anyone familiar with Deirdre Lundy, who's like our GP guru in Ireland for HRT, she's coined the phrase, you know, horses pee. Basically, they used to extract estrogen from pregnant horses' urine, and that was what was put into the oral HRT that was in the study. It wasn't human, it was oral. So we know that this now has a huge impact on the risk of clotting, the risk of heart disease, the risk of breast cancer, all of that because of the type of HRT and how it was given. The second thing is that a lot of the women in these studies were in their late 50s, early 60s by the time they started the HRT. And if you can remember back, I mentioned that ideally HRT should be started within 10 years of the last period. So these ladies had no estrogen for probably 10 years. We know their risk of heart disease had climbed up. We know as we get older, our risk of breast cancer goes up. So therefore, all of those risk factors were relevant to why there were high levels of heart disease and stroke and breast cancer in this study, but they weren't accounted for in the results. It was just a blanket HRT is causing this, and it wasn't just the HRT. And then the other thing in the study was that a lot of the women actually had already been on HRT before the study started, so they were on it for longer. So we couldn't really draw conclusions as to what the right length of time to be on it was. So thankfully, when they re-looked at this study and realized all of these flaws, we realized a few good things that come out of it. The women, as they followed them on, the women who were on the HRT actually had a lower risk of dying from all causes. So regardless of the increased risk of breast cancer and the increased risk of heart disease on it, they actually had a lower risk of dying from other causes. We know as well, and I'll talk about this in a second, there's a reduced risk of breast cancer if you're on estrogen-only HRT. Now, that's a little bit of a specialized area, and that's for ladies who don't have a womb. If you still have a womb, you have to use the 2 hormones. But it's something very nice to be able to tell women who come in who've had a hysterectomy, and often those ladies have struggled a lot because they maybe had heavy bleeding or fibroids or endometriosis. So for once, they're getting good news that, hey, we're going to give you some HRT and it's actually going to reduce your risk of breast cancer. So that's a nice thing to be able to tell them. There is a small increased risk in breast cancer with the 2 hormones, the combined HRT, and we'll look at that in a second. There's a reduced risk of heart disease and mortality, so dying, if taken within 10 years of your last period. LMP is your last menstrual period, you're under 60. So I think we've touched on that before. This came out of the follow-up on the Million Women study. So lots of good stuff there, and also the fact now that we've got newer HRT. So it can't be that easy. Well, it is. And it's one of the nicest things to be able to do as a doctor. When you go through all of this education with the lady, you go through a questionnaire, you go through her past history, and you say, you can take HRT if you want to. It's lovely. And what's even more lovely is when those ladies come back 8-10 weeks later and they say, oh my God, I feel so much better. So it is that easy. It is. Okay. Normally what I do is I start them on something relatively low, their own choice of whatever they want to do, a gel, a patch, whatever it is. They go away for 8, 10, 12 weeks, whatever it is, and then they come back and we see how they're doing. I normally will say to people, if somebody comes in and they are literally flushing and sweating in front of me, I know that HRT is going to settle that within, now I've had people say days to me, definitely within a week or 2, those sweats and flushes are going to be a lot better. So when women come back then, we say, look, what's better, what's not better? Do you think there's more scope for improvement, whatever it is? And we talk about leaving things as they are for another bit, or we tweak doses or whatever it is. I think we mentioned it earlier when I spoke about, is it just my crazy hectic life or is this perimenopause? We often do this approach. Give it a go. Let's try it for 2 months, 3 months, get tuned into noting down my symptoms, my cycles, all of that kind of stuff, and say, is this helpful? And I would say, not being biased, I don't have figures for it, but the majority of women come back and say, oh, I didn't realize that actually I was suffering, or my friend at work has said, what's different? Or my husband has said, you're back, or whatever it is. Most women do find that there's an improvement. I suppose and again, yeah, we might need to change things around. Some people might start on a patch and find they don't like it and want to change to a gel. All of that can be done, no problem at all. And you can take it for as long as you wish. Just something else that I like to mention here as well is that, you're not going to go on HRT and then be Davina McCall. If you were always a shy, quiet person who liked their own company and, found it hard to get out for a walk and doesn't like the gym, you're not going to go onto your patch and then suddenly find you're up doing the 6 o'clock aqua aerobics. It basically, it brings back what that lady who said, I just want to be me again. That's what you're trying to achieve. You're trying to get you back to the way you were before this started to happen with the hormones. So it's not a miracle worker. And some women do come with, 20 years of back pain or 20 years of anxiety or whatever it is. And I can't promise them that HRT is the answer. Absolutely, if they want to try it and see if it's going to help, we can do that. But we have to be realistic as well about what it can do. I'm just going to fly through the next slide because it's more medical, but there are some people who can take HRT, okay? And this would be something that you discuss with your doctor. So very few people, I would have to say. So an estrogen-dependent malignancy, which is usually a womb cancer or a breast cancer or something like that, okay? Undiagnosed bleeding from the vagina. What I would say there is that once we find out what it is, absolutely you can have your HRT, but we need to find out what it is first, okay? Endometrial hyperplasia is similar to the bleeding. It's where you've got thickening of the line of the womb, and it probably is going to need a D&C or a biopsy to find out what it is first. And then if all is okay, you can come back and get your HRT. Somebody who's just recently had a stroke or a heart attack, we need to be careful with, but a past history of that is not a reason not to have it. Untreated high blood pressure, once we get the blood pressure under control, happy days, you can have it. Active liver disease would be the other one because it's broken down by the liver. So the breast cancer risk now, I always get, oh yes, we're running out of time, which I knew was going to happen to me. So the breast cancer risk, I'll try to go through it as fast as I can. We know that there's no increased risk of breast cancer up to the age of 51. There's a huge lifestyle benefit or effect of breast cancer, of our lifestyle on breast cancer risk. So things like being overweight, excess alcohol use, exercise, they're all really, really important factors in our breast cancer risk. And I'll show a slide now in a second that demonstrates that. We do know that the newer body identical hormones are being studied at the moment, and maybe there is going to be a positive, I suppose, outcome there that we can say, look, actually that risk that we did think was 5 extra cases or whatever per 1,000, it's actually less than that. But at the moment, the figures that we quote are the slide that I'm going to put up next. So this is the Women's Health Concern. It's a really good infographic. I think it's really clear. So it's basically women between 50 and 59 in the UK. Per 1,000 of those women, how many will get breast cancer in the next 5 years? So if you look at the top row there, which is the blue, there'll be 23 cases per 1,000 in that age group over the next 5 years. Okay, and that's the baseline risk just by being alive in this part of the world and the lifestyle that goes with it. The next one then is combined HRT, which is the 2 hormones that we spoke about. So what we quote at the moment is that there's 4 extra cases per 1,000 over the next 5 years. So it's not a big risk, but some women do look at that and go, it's still there. If we come down then to the last few, so if we come to the one, it's 1, 2, 3, the fifth one down, sorry, that's alcohol. So women who drink a large glass of wine or a pint every day or more, there's actually 5 extra cases of breast cancer per 1,000 over 5 years. So it's actually a higher risk than being on HRT. And I know, like, I see so many women in our age group who come in and, they're stressed and they're busy and they're not sleeping and they're having a drink every night or whatever it is. And it gets into a bit of a habit and they're shocked to realize that that's actually putting them more at risk than if they were on the HRT. If we come down to the second last one, you can see that it's overweight. So if you're 2 stone or more overweight, there's actually an extra 24 cases of breast cancer per 1,000. So it's way, way higher risk again than your HRT. And the last one I love because I'm into sport and exercise, but basically if you take half an hour of exercise 5 days a week, 7 less cases. So I think sometimes that can reassure women that there is a risk of breast cancer, but lots of other things that we do in our day-to-day life are actually making that risk even more. I don't really have time to talk about the breast cancer, family history of breast cancer, but again, if you go to your doctor and someone who knows about menopause, they will be able to talk you through that. I don't have time to do vulvovaginal symptoms either, but again, just to say it's really, really common. And if you're not keen on the HRT issue, we have loads of treatments for that as well. So I'll just flick through that. But it's a huge factor and often one that women don't disclose. Everyone will tell you about they're not sleeping and their sweats, but they don't often disclose that intercourse is painful or whatever it is. So just a little bit of light relief there from the ladies who some of us might feel that we're putting tablets and patches and pessaries and all that kind of stuff. Again, there's loads of positives to this time of life as well, and I don't really have time to say it all, but it's not all bad, and often it's a time of freedom and, a time when you can really start to just reevaluate your priorities in life. And the take-home messages, I suppose, would be get to know yourself, know your cycle, know your symptoms, start tracking it. If you're going to your doctor, I would recommend ask for a double appointment or a longer appointment. You can't get through this in 10 minutes or 15 minutes, especially if you're going to, if you're getting your prescription and you want to talk about something else, you can't do it properly. And both for you and the doctor, it's more beneficial to look for a longer appointment. Don't underestimate the lifestyle. We don't all have to go on HRT. Many of us can get on fine without it. And I think we underestimate that our activity levels, our alcohol, our diet, our exercise habits, all of that can have a really powerful effect on our symptoms and also on our long-term health. Ask for help. Like, I think we're getting better at that. There's so much available out there now, from chat rooms to friends and all of that kind of stuff. So do ask for help. Educate yourself, also educate your loved ones. And we actually had a chat before we started here. I asked, were there any men going to come to the presentation? And I think I was told no. So that's even an issue in itself. Now I think, to be fair, it can be a bit overwhelming and scary for them. But I've had women come in with their husbands, or I've had women come in to say, my husband heard your ad on the radio and he called me aside and said, look, would you go along and see what she has to say? So I think sometimes they can be quite confused by it and they want to talk about it, but maybe they don't know how to bring it up. So educating them on it as well is important. And see this time of life as a chance to really just reevaluate your health. Cholesterol, blood pressures, activity levels, all that's so important. So I think that's the end. And contraception, that's something again to talk about with your doctor. I have some resources here that will be useful, and I think Deirdre has recorded it, and if anybody wants to copy the slides or whatever, no bother at all. So they're all there. And then I think, not all of us are lucky enough to get to the stage where we talk about menopause. So this lady rocks it. So thank you.
Sinead, thank you very, very much. Dr. Sinead Fitzpatrick, GP from Waterford. That has been absolutely amazing, so informative, and I love your approach, Sinead. And I think I speak on behalf of everybody here. We had over, I was just looking at the numbers there from time to time, we had over 115 people at one stage who tuned
Just
into
as well, I
the
didn't know
webinar
that.
session. So that is fantastic. Now we do have, I suppose a lot of people have been putting in questions, and unfortunately we were trying to get through so much today that we're not going to be able
Yeah.
to get around to the questions. However, we'll take some of them and I'll send them to you, Sinead, separately, and
Perfect.
hopefully we'll try and address some of those.
Yeah.
The other piece, as you say as well, we're happy to share this presentation. It's still recording
Yeah.
at the moment, and we will do that, and we'll share the presentation. If anybody would like the slides, if they want to drop me an email, my email address, again, it's Deirdre, so it's DEIRDRE, A for Anne, Dunne, DUNNE, at hse.ie. And I will send them to you, no problem. And just the last piece, I suppose, we'd love some feedback on the session today. So if you drop me an email, we'd love to hear what you know. I'm sure it'll be all very positive, but what you thought about it. Apologies for the minor, I suppose, technical glitches. We got them sorted straight away. And on that note, just to thank very specially Jill Toohey and Claire Summers from ICT, who were great support to us in setting up our first webinar today.
Yeah.
So thank you very much to everybody for attending, and we look forward to hearing your feedback. And Sinead, thank you very much for all of your
No
time.
bother.
Thanks a million.
No bother.